So we've spoken very quickly about some of the dental aspects through mouth breathing which might affect the development of sleep disordered breathing when it starts in a child. There are other aspects from that which lead into other pathological areas. For instance, if you have this lack of vertical support, as we call it, on the back teeth because of failure of eruption of the lower teeth, possibly also the upper teeth, then what we then get is the ability of the lower jaw to get too close, in effect, to the upper jaw. This used to be called overclosure, for obvious reason. It's the face overclosing. Most dentists don't like that phrase now because it infers that something's wrong. And since we're not taught that there is a possibility that that can be wrong, it doesn't sit very well. So most dentists prefer to keep that comment as it relates to people with complete dentures, especially those that are either worn down or never built to their optimal height, because then those people are genuinely overclosed. But my argument would be that you can have overclosure if you accept that sometimes the lower teeth cannot grow to their maximum height because of the tongue sitting over them, and a lot of people would disagree with that. But if you accept that, then you would also, by default, accept that the jaws can get too close together, and that's overclosure. And not only does that cause the tongue to move back, thereby increasing the likelihood of an airway compromise, but also because of the inclination inside of the upper incisors, as the jaws get closer to one another, the lower jaw is then driven backwards and upwards, instead of the normal growth, what they call growth vector, which is for the face to grow down and forwards. Now obviously there are different individual situations going on because this is genetically driven too. It's also driven by, as we've said, familial factors and a whole host of other things. But we're limiting ourselves to the dental component. And I say dental, I should call it oral and dental component. Now what happens is, because the lower jaw is the last bone in the body to stop growing, we also see some increase as the length of the jaw is increasing. We also see some compression back here. Now, again, this is a very controversial subject because orthodontists generally feel very strongly against the possibility that one can, in their words, grow the mandible. But in actual fact, what we're looking at here is an optimal growth of the mandible, and that is encouraged by adequate growth eruption vertically of the teeth. But that requires an observation that the teeth are not ideally developed in height. And whilst we as a dental profession tend to look at the level of the teeth, and then we take models either by impressions or by scanning or whatever we're doing now, we have these study models and we hold them together. And with all due respect, which generally means with no respect, that makes no sense whatsoever, because what we're now looking at is a purely dental and orthodontic straight teeth assessment of what is an orthopedic problem developing in 3 dimensions with the face. The teeth, let's face it, are fitted within the jaws. There are, and I grant, lots of ways of moving the teeth, and orthodontists are very, very skillful in moving the teeth. But what about the jaws? And that's where the orthodontists, and I'm not disagreeing, I'm just saying this is a different viewpoint, but this is where orthodontists tend to differ, because their argument is it's it's based on a purely genetic basis. I remember I had a good friend who was an orthodontist, and he said what you have to remember is the jaws come from the mother or one of the parents, and the teeth come from another, and that's why you have the discrepancy between the two. I don't think it's quite that simple. I think that what we must do is we've got to look at a child as a small seed growing, and I think what we have to do is we have to look at changes that take place that are clearly not right in the way they're growing. If it's in a flower pot that's over to the side, then obviously the shoot is going to change direction, which means it's moving through 45 degrees. If then the flower pot's turned the right way up and it allows the sun to go all the way round, then obviously the flower or whatever it is going to grow normally. And so that's what we should be looking at doing. We should be looking at children not as children who become people who we can treat, but we should be looking, and I'm not the only one that says this, we should be looking at children and saying, where is this child going? What is this child's growth and development pattern going to be? How do we need to intervene? And I would argue that from an airway standpoint, we must.